So good morning, everybody. On a not so very beautiful day today, there's a lot of smoke outside. I'll be talking about principles of medical oncology, and yeah, okay. So when I got this topic, I thought, okay, let me first see the definition of medical oncology, and this is what Holland and Fry, the textbook that we have, has to say about it. It says a medical oncologist is an internist who has undergone additional specialized training. So, a good medical oncologist applies the thoughtful approach to problem solving learned as an internist to a body of knowledge that includes patients with cancer. So, what I'm trying to say is a lot of medical oncology also involves a lot of basic medicine because need to look at the cancer drugs, and then we need to look at how the body reacts to those cancer drugs and look at multiple different associations along with that. Now, the more important part is that all this is done in teamwork with multiple other disciplines, especially surgeons, the radiation oncologists, pathologists, and of course the molecular pathologists in today's world, with nursing oncologists, radiologists, oncologists, neuro-oncologists, gynec-oncologists, rehabilitation medicine and physiotherapists, and of course pediatric oncology. And last but not the least, infectious diseases are also common complications of cancer and their treatments. So we need to know about antibiotics as well, along with our chemotherapeutic agents. So this is the broad overview of what we're going to be discussing today. We'll talk about the history and classification of these chemotherapy drugs, their mechanism of action, some basic principles of chemotherapy, how to assess responses, and a little bit about drug resistance. And I'll start with 3 to 4 slides just about basics of cancer. So as we know, this is the definition of cancer: an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissues and persists in the same excessive manner after the cessation of stimuli which evoke the change. So we have normal cells. There are a few abnormal cells which develop. They multiply. They escape the various control mechanisms of the body. They develop invasiveness. They develop angiogenesis, and then it leads to cancer. So the three most important characteristics to define this malignant phenotype are escaping control mechanisms, invasiveness, and metastasis. We know there was this hallmark paper, the hallmarks of cancer cells, that was originally published in 2000, which looked at these are basic principles. They took all the different aspects of cancer cells and put them into various principles, and these were the 6 main or the original principles, which is sustained proliferative signaling, evading growth suppressors, activating invasion and metastasis, enabling replicative immortality, inducing angiogenesis, and resisting cell death. Now, in today's world, a lot of new dimensions have been added to this. The article was updated in 2011 and very recently in 2022. I think a class has already been done on this, so I just wanted to put this here for completion's sake. This is very to really simplify the process of metastasis. So the transformed tumor cells develop blood supply, they develop angiogenesis, and using these blood vessels, the cancer cells then develop motility. They go inside the capillaries, venules, the lymphatic vessels. They attach onto different cells in the vessels like lymphocytes, platelets, cause aggregates, and go into different places in the circulation, and wherever they find space, they get arrested in the capillary beds. They adhere there, again with the use of a lot of cytokines, chemokines, and other chemicals. They extravasate into the organ parenchyma, and if the microenvironment is suitable, they again start with the same procedure all over again. They develop angiogenesis and so on and so forth, and hence this leads to metastases and metastasis of metastases and so on and so forth. So coming to the main topic, what is cancer chemotherapy? It's a modality of cancer therapy that involves the administration of chemical agents. So the point is chemical agents because we have a lot of other drugs to target cancer these days, including immunotherapy, targeted agents. We'll be restricting ourselves to chemical agents today to destroy cancer cells. So the aim of cancer chemotherapy is to cure where possible and palliative where cure is impossible. And this effective use of this chemotherapy needs a deep understanding of principles of tumor biology, cellular kinetics, pharmacology, and drug resistance. So, to start with a small overview of the history, the arsenic compounds were used in traditional Chinese medicine from a long time back. And in 1865, arsenic was also used as a component of Fowler's solution to treat CML and Hodgkin's lymphoma. However, the major breakthrough came during World War II when a harbor was bombed in 1942, 1943, and one of the ships in that harbor was carrying nitrogen mustard, liquid mustard gas. And it was noted later that the people who came in contact with the gas, the ones who survived also, they developed blistering of epithelial surfaces, reduced white blood cells, and profound lymphoid and myeloid suppression. Later on, that was detected on autopsies. So, using this information, Goodman and Gilman, who were pharmacologists from Yale, they reasoned that this could be used to treat lymphoma and induce lymphopenia. So, in 1942, they used nitrogen mustard to treat a patient with non-Hodgkin's lymphoma, and this was the first time that chemotherapy. It was shown that chemotherapy can induce tumor regression. Building onto that, Sydney Farber used antifolates to successfully induce remissions in children with acute lymphoblastic leukemia. Earlier, this disease was considered as a death sentence. It was worse than, it was like type 1 diabetes before insulin came in. I'm not sure how many of you've read the book, The Emperor of All Maladies, but I would really recommend it. That tells the story very nicely, actually. So, leading on to that, then other drugs were developed. Methotrexate was used as a single agent in 1958 to cure choriocarcinoma. Then cyclophosphamide came into the picture in 1959. Then combination chemotherapy came into the picture in 1965 to induce long-term remissions in children with ALL. And in 1970, lymphoma was cured with combination therapy, and so on and so forth. So, points I would like to note here is that 1978 cisplatin was approved, and that's, as we know, it's a backbone of chemotherapy for head and neck cancer patients, as well as paclitaxel in 1992, which was approved and which is like the first blockbuster oncology drug. So cisplatin or carboplatin, paclitaxel, the two drugs which form our the basis of our backbone of chemotherapy, right? And then now the paradigm is shifted from just chemotherapy to targeted therapy. From 2001 onwards, imatinib was developed for CML. EGFR gene in lung cancer was, the mutations were discovered, and so on. The EGFR TKIs were developed, and so were targeted treatment therapies like VEGF inhibitors. So this is just a short overview of the 10-year survival estimates of children with acute leukemia, ALL, treated at St. Jude Children's Hospital from 1962 to 2007. So if you look at this, in 1962, hardly 10% of patients used to have long-term survivals, and this became more than 90% in 2000 to 2007. And all this has been due to the development of chemotherapy. And as I will mention before, it's not just the drugs, it's also about how you give these drugs. So, a very basic mechanism of action and how these drugs act, I'll try to keep it as simple as possible. So, the cell cycle, so there are two phases. One is the growth phase and one is the G0 phase. The G0 phase is the resting phase of the cell, where the cell is not undergoing any plans to reproduce. The G1 phase is when the cell decides to take this decision to reproduce, and it starts by preparing for DNA synthesis. So this is a phase of growth, the G1 phase. Coming on to the S phase, this is the DNA replication phase, in which maximum DNA replicates. And then once the DNA replication is complete, the cell enters the G2 phase, which is preparation for mitosis as well as growth. Once G2 phase is complete, and all these phases have various checkpoints where the cell goes into growth arrest if these criteria are not fulfilled. And that is the basis of another kind of agent for cancer medicine these days. So this entire G1 to G2, G1, G2S phase is called as interphase, after which the cells enters into the mitosis phase, the M phase, which is again prophase, metaphase, anaphase, telophase. I'm not going to go into details. Now, what do the chemotherapeutic agents do? So we divide them into two. We divide them into cell cycle phase specific, where agents have major activity in a particular phase of the cell cycle, and these are schedule dependent. And then there are cell cycle phase non-specific agents, where agents have significant activity in multiple phases. So you can give it at any time, and these are mostly dose dependent. So examples of cell cycle phase non-specific agents are the platinum compounds, carboplatin, cisplatin, oxaliplatin. We have the alkylating agents, cyclophosphamide, busulfan, carmaztin, lomaztin, meclorethamine, melphalan, thiotepa. The G1 phase dependent drugs are asparaginase and corticosteroids. The S phase, which is the synthesis phase, usually it's antimetabolites which work here. So methotrexate is very important. 5-fluorouracil, both of these drugs we use in head and neck cancer. Doxorubicin, capecitabine, cytarabine, fludarabine. The list goes on, so on and so forth. Gemcitabine, hydroxyurea, to name a few. Certain G2 phase dependent drugs are bleomycin, irinotecan, mitoxantrone, and topotecan. And M phase dependent are the ones that actually inhibit or cause microtubule arrest, which is the vinca alkaloids, vinblastin, vincristin, vinorelbin, the podophylotoxins, etoposide and teneposide, and the taxanes, docetaxel and paclitaxel. Again, docetaxel, paclitaxel being a common component of head and neck chemotherapy regimens. So I'll quickly go through the different agents. So alkylating agents, they target DNA, produce alkylation through formation of intermediates. These are not non-phase specific, as we discussed, and we've already spoken about the various drugs. I would like to mention specifically the common drugs being cisplatin, carboplatin, oxaliplatin, cyclophosphamide, ifosfamide. This is what we use in daily clinical practice in most of the solid tumors and sarcomas. And temozolomide is what we use in brain tumors, and the others are mostly used in hematological malignancies. So anti-metabolites interfere with DNA synthesis. I'll get back to this later. They are mostly structural analogs, or they inhibit specific enzymes. And these are S-phase specific. Again, most of them are used in lymphomas and leukemias. Notably for solid tumors, we have 5-fluorouracil along with leucovorin, capecitabine, gemcitabine, methotrexate, pemetrexate. Raltetrexate is not really used that often. So methotrexate and pemetrexate are important. Pemetrexate mostly is a drug that we use in treating lung cancer, non-small cell lung cancer. Uracil and Tegafur. Anti-tumor antibiotics cause linkage of double strands of DNA and prevent replication. They are mostly derived from microorganisms and are cell cycle specific. So we have actinomycin D, bleomycin, daunorubicin, doxorubicin, a variant of doxorubicin called liposomal doxorubicin, to name a few. Mitotic spindle agents, as I mentioned before, they bind to microtubular proteins. So they inhibit microtubule assembly, resulting in dissolution of mitotic assembly structure, and the cell gets arrested in M phase. Notable examples are docetaxel, paclitaxel, paclitaxel-bound, albumin-bound paclitaxel, cabazitaxel that we use in prostate cancer, eribulin, mostly in breast cancer and sarcomas, which is a non-taxane tubulin binding agent. It's derived from a marine sponge. And we have the vinca alkaloids, vincristin, vinblastin, and vinorelbine. Coming to topoisomerase inhibitors, so DNA topoisomerases 1 and 2 are enzymes which are very important for transcription, replication, and mitosis. So these particular drugs are divided into classes of topoisomerase 1 inhibitors, which are irino and topotecan, and topoisomerase 2 inhibitors, which are etoposide and teneposide. We use etoposide as a component of oral metronomic chemotherapy quite often. Other miscellaneous agents notably are asparaginase that we use in leukemias, estramastin, and hexamethylmelamine. So this is the main diagram where I want to show how these drugs act at different parts of the DNA, RNA, protein transcription cycle. So the precursors form either purine or pyrimidine inhibited by 5-FU and mercaptopurine. Then these form ribonucleotides, and this is inhibited by methotrexate, which further go on to form deoxyribonucleotides, which forms DNA. So hydroxyurea, cytarabine, alkylating agents all work at this level. DNA gets transcribed to mRNA, and this is where cytotoxic antibiotics and trocarbazine work. mRNA further forms the coding for proteins in the cell, and these proteins further go on to form enzymes or microtubules or receptors to further carry out the body function. And Vinca alkaloids work on the microtubules. So this is a broad overview of all the different kind of drugs that we have. Now coming to how we use these drugs. So principles of chemotherapy, a lot of experimental and mathematical models. So you know, it was an evolving phase, as you saw in the history. So people just knew that these drugs act. How did these regimens become or come into use the way we use them today? You know, the dosing, how often, when, the cumulative doses, that all came from these initial experiments, mostly done in cell lines to begin with, and then they were built up from there. So what I want to say is that this is a very long procedure. As you can see, it started off in 1940s, and it is still a learning process. We're still evolving, right? So now this started off with experimental and mathematical models, which attempted to describe the fundamentals of tumor cell growth and kinetics. Then they used those principles of tumor cell growth and kinetics, and then figured out how to give chemotherapy according to these principles. So the best drugs in the world are useless, or even worse if they're not used properly. Now, again, I'll start off with the cell cycle and growth fraction before I go on further. So the growth fraction is at any particular point of time, some cells are going through the cell cycle while other cells are resting. The ratio of proliferating cells to cells in G0 is called the growth fraction. A tissue with a large percentage of proliferating cells and few cells in G0 has a high growth fraction, and a tissue composed mostly of cells in G0 has a low growth fraction. So, for example, solid cancer tumors generally have a low growth fraction. A lot of cells are not dividing at one particular point of time, like head and neck cancers. And they thus respond poorly to chemotherapy, and most cases need to be removed by surgery. So, a very important aspect of treatment in these tumors is surgical. Coming to disseminated cancers as well as hematolymphoid malignancies, usually these tumors have a high growth fraction and generally respond well to chemotherapy, may not require surgery. So this was the first law or the first hypotheses that came in regarding how cancer cells proliferate. So if you look at this, the X and the Y axis, this shows that the tumor grows exponentially, right? So this is the first of the Skipper's law, that the doubling time of proliferating cancer cells is a constant. And this states that the plot of tumor size over time on a semi-log graph forms a straight line. Now, Skipper's second law states that chemotherapy agents follow first order kinetics. That is, a fixed fraction of tumor cells are killed regardless of the tumor size. So, no matter how big the tumor, a fixed fraction of the cells are going to be killed. For example, a 90 log kill reduces the cell number by 1 log to the base 10. That is a 1 log kill. Sorry, a 90% kill. A drug dose that would result in a 3 log kill, that is 99.9% cytotoxicity, would reduce the tumor burden of an animal, that is 10 power 8 leukemic cells to 10 power 5. A 99.9% does not mean that the tumor is eradicated by 99.9%. So building on this, they said that since a major limiting factor in chemotherapy is cytotoxicity to normal tissues, only a limited log cell kill can be expected with each individual treatment. So I'm coming to this graph. I'll be explaining this graph in detail. But coming to this particular line, so what the hypothesis says is that you keep giving doses at frequencies and eventually the tumor is going to come down to zero. Right. However, this is only this does not hold true in regular clinical practice, and even in the absence of tumor regrowth, several cycles of therapy would be required for eradication of this tumor, assuming it was sensitive to the drugs employed. And this model also suggests that given enough doses of chemotherapy, a complete cure can be hypothetically achieved, which is not representative of those with advanced cancer. Now, building onto this, this is a very important graph or diagram, and I'm going to discuss it in detail. So, if you look at this dotted line, this is when the patient becomes symptomatic. Everything below this is the preclinical phase of the cancer. And usually a 1 mg mass when the cancer is actually very, very small is approximately 10 power 6 cells in that particular tumor. Now, 1 gram mass is usually when it becomes clinically palpable, and this happens at around 10 power 9 cells in the tumor. And from there on, it's a very short jump onto 10 power 12 cells, which is basically consistent with death. This is where the tumor exceeds its carrying capacity, right? Now, what surgery does is it brings down this mass to a certain level, and then chemotherapy or other drugs treat the occult metastasis or the small tumor that is remaining behind, and radiation is also included in that. When we talk about curative chemotherapy, I just discussed that. When we talk about palliative chemotherapy, or when we give less doses, or we don't give doses according to the proper density, then the tumor regrowth out smarts the tumor cell death, and then the tumor keeps on increasing, and then it reaches the point of criticality. So now tumors don't really follow this kind of a kinetics model. Tumors follow what is called the Gompertzian growth curve, which is the most common pattern in nature. The leukemias usually follow the exponential growth pattern. That is where that model was described. Right now, how does this log kill apply to cancers that grow by other than exponential kinetics? So, if you look at the Gompertzian growth phase, the growth curve, it's a sigmoid function. It says that the initial growth of the tumor is slow, and then the later growth of the tumor is slow. Later on, earlier, because the tumor takes time to double and increase in size, and it is recruiting all the blood vessels for angiogenesis and all that. Later on, it exceeds its carrying capacity. So at some point of time, after a certain size, some of the tumor cells are dying, some of the tumor cells are proliferating. So the growth kind of starts to plateau. So this is the phase that we need to watch out for. In between phase, where the tumor kind of follows exponential growth. And this is what is utilized by cancer chemotherapy cells, right? So below the diagnostic threshold and up to a specific time point, tumor is curable. We've discussed this, and we've already discussed this slide. Coming to the chemotherapy aspect of this particular growth curve. So the growth fraction peaks when the tumor is approximately 37% of its maximum size. And under the Gompertzian model, when a patient with advanced cancer is treated, the tumor mass is larger. So its growth fraction is low, and fractions of cells killed is therefore small. And the response to chemotherapy in drug tumor depends on large measure on where the tumor is at its particular growth curve. So the smaller tumor will grow slowly, but a large percentage of cells are dividing, hence chemotherapy works well. A medium-sized tumor grows more quickly, but with a smaller growth fraction, and a large tumor has a small growth rate and a large growth and a small growth fraction. So this is where the Norton-Simon hypothesis builds upon. It says that chemotherapy results in a state of regression in tumor volume that is proportional to the rate of the growth of an unperturbed tumor of that particular size. Hence, this is not independent of tumor size, but rather inversely proportional to it. So, to very simplify it for everybody, is that smaller tumors exhibit greater cytoreduction in response to chemotherapy due to their exponential growth rate. And this is where the concept of dose density came in. So this is a diagram showing the different ways in which we can kill tumor cells. So the standard dose regimens will kill a certain amount of tumor cells at each dose. However, at some point of time, the growth of the tumor may exceed the number of cells being killed, because those cells will go into the exponential growth phase from a slow growth phase, and they will start proliferating a little more. I hope everybody's understanding this. I'm trying to make it as simple as possible. And if we try to escalate the doses, yes, it may lead to higher number of cells being killed, but then there is a limit to this, because the other cells of the body also get affected. What dose dense regimens do is you start giving the drugs very close together. So you try to get the tumor in that phase where the log kill is going to be great in the exponential phase. So this is where the subsequent chemotherapy must be developed sequentially in the shortest possible intervals to be most effective. So these hypotheses led to several novel ideas. which were validated through clinical trials over years. The first idea is that dose level is important, but it is not strictly, you don't need to escalate each time to get the maximum effect. You need to know when to give it and how to give it. The second idea is that the density of therapy is important. So combinations that reduce the dose level of each component could therefore be worse when we give reduced doses, or those regimens where we're giving prolonged chemotherapy. Instead of a 3 weekly or a 2 weekly cycle, we're giving it over 4 weeks or 6 weeks. It gives you time for the tumor to increase again, right? And of course, develop more drug resistance. So this is a very short representation of how we can dose different chemotherapy regimens. One is the conventional 3 to 4 weekly dosing. Dose intense is when you increase the dose. I'll give an example of breast cancer. So FEC 50 versus FEC 100, where the higher doses led to a better clinical outcome. Dose dense regimens, again, most commonly used in breast cancer, dose dense AC and dose dense taxanes, as we all know, leads to better survival outcomes, where we're giving them closer apart. Intense dose dense regimens was also studied. There was a trial called Panther trial in breast cancer. However, it did not really take. And a tailored dose dense regimen where you give it according to the patient's toxicity. So, like a dose adjusted REPOC, not technically doesn't need to come into this, but something similar to that, right? In treating lymphomas. So, so as we remember the history of chemotherapy slide that I showed earlier, we first started off with single agent drugs. So the initial regimens just looked at the kinetics of bone marrow recovery, and sometimes, yes, it did lead to complete response. We still use single agents in certain settings like choriocarcinoma, methotrexate, or dactynomycin. However, at the end, these were the initial drugs that we used to treat various cancers: cyclophosphamide for Burkitt, cisplatin for head and neck squamous cell carcinoma, carboplatin for testicular cancer, again used in certain select circumstances. But it was noted that tumor cells would develop resistance. So again, another hypothesis, but this is the last one, and this is all very important. So bear with me. So this is again a mathematical model of genetic resistance, which says that tumor cells acquire mutation even before exposure to chemotherapy drugs. So there's a baseline mutation in each tumor, and drug-resistant mutations arise at a measurable frequency. So obviously, the larger the tumor burden, the more likely a mutation will occur. And if you give two drugs together, then the probability of resistance comes down, right? And this is the rationale of giving combination therapy. So that's all you need to know about this. It's a complex subject, and I won't go into details. An early introduction of dose-intensive alternative agents is most likely to prevent a large number of resistant clones, increasing efficacy. So the example that I can think of is your VAC-IE regimen in Ewing sarcoma. So this is how the paradigm shifted from single chemotherapy to combination chemotherapy, and this was all on the basis of these particular tumor models that were studied earlier. So the rationale behind combination chemo is that it provides maximal cell kill within the range of toxicity tolerated by the host for each drug, as long as dosing is not compromised. It provides a broader range of interaction between drugs and tumor cells with different genetic abnormalities in a heterogeneous tumor population. It may prevent and or slow the subsequent development of cellular drug resistance. So there are certain basic principles that we use for combination chemotherapy. All drugs must have single agent activity with non-overlapping toxicities, different mechanisms of action and resistance, optimum dose and schedule to optimize dose intensity and dose density, and should be individually titrated in individual patients to end organ toxicity to optimize adherence to schedule. So for example, in head and neck cancer, we use DCF, docetaxel, cisplatin, 5-fluorouracil. So all of them have different mechanisms of action, as we discussed earlier. All of them have single agent activity in head and neck cancer, and all of them have non-overlapping toxicities. Except, well, of course, neutropenia, but well, that's acceptable, right? So we look at the shortest interval between chemotherapy to allow for recovery of the normal tissue as well when we develop these regimens. So these are common examples of combination chemo regimens. For example, in breast cancer, we have doxorubicin and cyclophosphamide. We do have cyclophosphamide, methotrexate, and 5-FU. We have the Hodgkin ABVD regimen for Hodgkin's disease, the CHOP regimen for non-Hodgkin lymphoma, the BEP regimen for germ cell tumor, ECF, we don't use it so often anymore, but yes, so on and so forth for different tumor types like FOLFOX for colorectal cancer, MVAC for bladder cancer. And this is another way in which we classify combination therapy regimens, those which can cure cancer even in advanced stages. So, for example, germ cell tumors, Hodgkin's disease, non-Hodgkin's lymphomas, choriocarcinoma, childhood tumors, which can achieve considerable prolonged survival in advanced stages, that is breast, ovarian, colorectal, lung cancer, head and neck cancer, other hematological malignancies like leukemias and myeloma, and those which can achieve prolonged progression-free survival as adjuvant treatment in non-metastatic disease. So like chemo regimens for breast cancer, colorectal and ovarian cancer. Now, coming to resistance, I'm going to keep this very short. Again, it's too complicated and beyond the scope of today's talk. So, mostly we divide resistance to cancer chemotherapy is either primary resistance, if you look at the first one, where the cancer does not respond to standard chemotherapy from the very first exposure, because that cancer already contains certain cells which are multi-drug resistant or inherently resistant to those drugs. And there are certain stem cells which are not really killed by these agents and which again proliferate and lead to redevelopment of the cancer. Then there is acquired resistance when the tumor initially responds to chemotherapy and then becomes resistant by acquiring mutations. This is diagram number C and diagram number D. So these resistant tumor cells, when you give the same drug or other drugs which again they are resistant to, that leads to no response and subsequently worsening of the tumor or progression. In short, this slide, there's a pictorial representation also. How do resistance mechanisms work for different drugs? So there is induction of thiol-containing proteins that quench the alkylators cross-linkers. There's induction of DNA repair enzymes, which repair the DNA damage that these drugs cause. There is induction of certain enzymes, which catalyzes the reaction of these particular agents and are needed for their activity. There is increased enzymatic destruction of the drug. There is compartmentalization of the drug. There is increased efflux of the drug out of the cell. So, or easily, there are high metabolizer patients which metabolize the drug very quickly, or there is overexpression of a drug target. For example, gene amplification of the DHFR gene gives resistance to methotrexate. So now search is ongoing to how to decrease resistance to chemotherapy, and hopefully another few years down the line we'll have more information on this. Now these are important terms that we use in clinical practice. I'm sure all of you already know this, so we'll quickly go through this. A neoadjuvant chemotherapy is usually given preoperatively. The rationale is to make one non-operable tumors operable, to achieve organ preservation, and to select sensitivity for specific treatment like biomarkers at a later date. And of course, we now look at pathological complete response also as an acceptable or a desired outcome in certain cancers like breast cancer. In head and neck cancer, again, there is some role of neoadjuvant chemotherapy for the first two points. In the adjuvant chemotherapy setting, post-operatively, the rationale is to kill micrometastatic disease and increase disease-free survival, as we discussed in the previous curves. Palliative chemotherapy is given to control symptoms or prolong life in a patient in whom cure is unlikely. Salvage chemotherapy is when a potentially curative high-dose regimen given in a patient who has failed or recurred following a prior curative regimen. Stem cell transplant using myeloablative chemotherapy is also part of a salvage chemotherapy protocol. Induction chemotherapy, it's very similar to neoadjuvant, except that here the intent is to induce complete remission in, say, for example, acute leukemias when initiating a curative regimen. And consolidation is when you build upon that with the repetition of the induction regimen in a patient who has achieved complete response with the intent of increasing cure rate or prolonging remission. Dose intensification chemotherapy strategy to overcome drug resistance to, again, we've discussed this earlier. And again, stem cell transplant or myeloablative doses also come into dose intensification. Maintenance chemotherapy is a long-term, low-dose, single or combination chemotherapy in a patient who has achieved a complete remission with the intent of delaying the regrowth of residual tumor cells. So this is again mostly used in acute leukemias. And in solid tumors, adjuvant capecitabine in breast cancer, we can consider that as a kind of maintenance chemotherapy. We also use, there's some data for using erlotinib in head and neck cancer. It's not a very strong data, but it's coming up. Coming to metronomic chemotherapy, which is the basis of palliative chemotherapy in head and neck carcinoma, once initial lines have failed, is the oral chronic administration of chemotherapy in low doses. So these low doses like cyclophosphamide, etoposide, vinorelbine, they have both anti-tumorigenic and more importantly, they have anti-angiogenic effect on tumor endothelial tumor cells. So these cells are 10 to 100 times more susceptible to chemotherapy. We've had data presented in ASCO last year as well as in ESMO this year from our own Indian investigators, where the role of metronomic chemotherapy, especially in head and neck cancers, is quite prominent. With regard to chemoradiation, so this is again a topic in itself. However, in short, it is integration of chemotherapy along with radiotherapy, where the drugs act as radiosensitizers. So they enhance the tumor response to the radiation and cause also protection of normal tissue because the doses are quite low. So, for example, we use cisplatin based chemotherapy and chemoradiotherapy in head and neck carcinoma patients. I've already discussed this. Concurrent chemoradiation, we've mostly discussed this. So the rationale is that we look at the micrometastatic disease outside the treatment field, and because of there's resistance to radiation damage, this helps with that. There is an inability to deliver an adequate dose to the target region because of risk of toxicity. So this enhances tumor sensitivity by delivering each agent when enhanced sensitivity to the other has been induced by the first agent. So they work synergistically. Now, the successful reduction of tumor mass by chemotherapy may improve tumor's blood supply, reoxygenation, increase radiation-induced cell kill, may alter the cell kinetics of the tumor in a favorable manner, permit radiation to be more effective in a particular phase of cell cycle, and conversely, radiation therapy may decrease the tumor mass, leading to improved blood supply and better drug delivery. So again, I will not go into the slides. It's a very busy slide. However, we need to know that there are certain drugs that we use as radiation sensitizers, notably, as I mentioned before, cisplatin, carboplatin in head and neck carcinoma, paclitaxel, 5-FU, iron and topotecan. Now, this was the scientific aspect and the preclinical aspect of the various chemotherapy drugs that we used. And coming to the practical aspects of these drugs, this is again extremely important. As I mentioned before, you need to know your drugs very well. You need to know your patient very well. You need to know a lot of interactions very well. And this is where the art of medical oncology comes in, along with conjunction with basic medicine. So how do we give chemotherapy? There are various routes. We can give oral chemotherapy, like I mentioned before, as parts of oral metronomic chemotherapy regimens. We can give them as in a subcutaneous manner. We can give them in an intramuscular manner, intravenous manner, which is the most commonly that we use. There's some data for intraarterial, intraperitoneal chemotherapy. Intrapleural and intrapericardial chemotherapy is mostly used to do DCIS procedures to decrease the event of recurrent effusions in cancer patients. We have intravesical chemotherapy for bladder cancer patients, intrathecal chemotherapy to look at the leptomeninges and the CNS. This is mostly used in head and neck, this is mostly used in hematolymphoid malignancies, and as well as those patients who have leptomeningeal carcinomatosis, and sometimes as prophylaxis as well. And topical, we use 5-FU based chemotherapy for certain indications. Now, how do we calculate the doses? So, one is, of course, weight-based dosing. Few drugs use that combination, the calculation. Mostly what we use is called a BSA, or a body surface area calculation, where the drugs are dosed according to so many mg or so many this thing per meter square. So, however, this has its own fallacies. You have to use the lean body mass, or the extreme spectrums of disease of weights. We have to be a little careful. There is some we need to calculate according to the if a limb is amputated. Although the dictum on that, I mean, it's divided. It's a gray area. And in children, mostly we give in mg per kgs. Children usually tolerate higher doses of chemotherapy quite better than adults because of their metabolisms. So we give higher doses. What we use for carboplatin is something called as area under the curve, where we use Calvert's formula. I think everybody should know this formula. And for my residents in medical oncology, I prefer that they learn how to do this on their own and not use online calculators. It's very, very important, and it forms a very important chunk of what we do every day in the clinics. So, even more important, before giving chemotherapies, we do a full chemotherapy assessment. We look at lab values of the patient. We look at their full blood count, renal function, liver function, where we have to modify doses for specific agents depending on how they are excreted or metabolized in the body. Certain drugs are contraindicated at certain GFRs and renal function and at certain liver function abnormalities. So we need to be very, very careful before we dose the patient. And we usually perform these assessments before every chemotherapy cycle and in between if required. An important aspect that you need to know, especially when we're giving methotrexate-based chemotherapy especially in head and neck cancer, is that we have to avoid third space occupation, because methotrexate goes into patients who have ascites or pleural fluid or generalized, and we need to drain all those extra collections before giving the drug. Otherwise, it will cause increased toxicity. So again, you need to know your patients. You need to know how to give your drug. We also look at the performance status of the patient by looking at the ECOG or the WHO performance status scale or the Karnofsky performance status scale. And this is something that every resident should know. This is something that even if somebody wakes you up in the middle of the night, and this is what I tell my residents, I don't know if they're there attending this talk right now, is that even if somebody wakes you up in the middle of the night and asks you about the performance status of a patient, they should be able to say it in their sleep, right? Another aspect that I've not touched upon here, which I'll touch upon later or I'll talk about it right now, is looking at the comorbidities of the patient. So I'll give you examples. Yeah, this is the slide. So this is what we look at when we decide what drug to give, along with obviously what is indicated in that particular tumor. So what is very important is age. You need to see how the patient is going to respond to that particular drug. Elderly patients usually develop more toxicities. For example, vincristine can cause a lot of constipation. Elderly patients already have that problem. So you have to know methotrexate can cause kidney damage. So you need to see elderly patients have a low GFR or poorly functioning kidneys or risk for kidney diseases. So you have to look at that also before deciding. With comorbidities, another important aspect is to look at hearing loss in elderly patients. So for example, we had a patient recently who needed chemoradiation for head and neck cancer, and he was blind. Now, cisplatin is known to cause nephrotoxicity and ototoxicity. So his kidney functions were okay. He was otherwise fit. But then we had a detailed discussion amongst ourselves. We had a detailed discussion with the patient. Since he was blind, he was only dependent on his hearing to carry out his entire daily activity, and his entire life depended on it. So we discussed about the risk in detail. We looked at other drugs which have reduced risk and can also form a chemotherapeutic regimen for head and neck CTRT, and then we proceeded along with that. We'll have to look at the nutritional status of the patient. Certain drugs are protein bound. So if the patient has hypoalbuminemia, you lead to more toxicity if you give full doses of the same drug. So we have to look at everything. We have to look at drug-drug interactions, which is very important. A lot of patients are on multiple medications for their various comorbidities. So we cross-check we cross-check drug interactions before giving any or prescribing any drug to any patient, or we modify. And sometimes we can't give the optimum drug because the patient's original comorbidity medication cannot be changed. So you need to know about that. For example, very common is anti-epileptic drugs. So phenytoin has a lot of drug interactions. Carbamazepine has drug interactions. Levira does not. Levetiracetam, Lacocet does not have so many drug interactions. So when we have a patient in whom we start chemotherapy, we try to switch over his or her anti-epileptic regimen slowly so that drug toxicity is minimized. We also look at the cumulative doses. There are certain drugs where you cannot give more than a certain cumulative dose, and I think everybody knows anthracyclines. You have to be very careful. You have to calculate the cumulative doses. You cannot re-challenge. We look at the CNS activity of certain of these drugs. Some of them cross the blood-brain barrier. Most of them don't. So capecitabine crosses the blood-brain barrier. Temozolomide crosses the blood-brain barrier. So these are all things you need to know before prescribing drugs to a patient. We look at the feasibility of administration of these agents. There are certain drugs which cause a lot of extravasation. 5-fluorouracil we prefer giving through a central line because it causes a lot of vasotoxicity. So we need to know that. So we insist upon putting a central line for certain drugs. This is all that you need to know in your clinical practice. Building upon this, adverse events are also very, very important. Most of these medications do have certain toxicities. You need to know each and every medication's toxicity profile. And again, the best drugs in the world are useless or even worse if they're not used properly. So this is called a chemo man. If you type it into Google, you will find this diagram everywhere. It's very cute and it's very easy to remember for like a general oncology field. Maybe not medical oncologists. We need to know more in detail. But most drugs cause general side effects because they work upon those normal cells also which are in a high proliferative phase. So basically your bone marrow, hair, skin. So these drugs can cause these toxicities: alopecia, nausea, vomiting, mucositis, skin changes, anxiety, sleep disturbance, altered bowel habits, bone marrow suppression, hypersensitivity, which is very, very important when it comes to platinum agents, which we use almost, I mean, it's the backbone of head and neck cancer chemotherapy. Neurotoxicity, nephrotoxicity, ototoxicity. I mentioned you earlier and gave you the example. Cardiotoxicity. We will not give cardiotoxic drugs in those patients who have underlying cardiac disorders or who have low ejection fractions. And in those where they are at a high risk, we have to monitor these patients more frequently and stop the drug if we feel it's patients are developing cardiotoxicity. So these are very specific side effects for certain medicines that you need to know, which is very important. For example, cisplatin and carboplatin cause ototoxicity and nephrotoxicity. Cisplatin definitely more than carboplatin. In the patient that I explained to you about recently, we offered him carboplatin, although again, it's not standard of care. We have other better drugs, but this is just an example to let you know. We need to be very careful about the GFR of the patient when we are giving them cisplatin in, say, head and neck cancer patients. Patients with single kidneys, we have to be very, very important. We usually perform a DDPA GFR to look at the baseline functioning of the single kidney to calculate doses according to that. So we have to see a lot of things. We have to discuss with the patient about potential nephrotoxicity. More importantly, and I'll come to that later, we give a lot of hydration. We give a lot of electrolyte along with cisplatin infusions. Vincristine causes peripheral neuropathy. Bleomycin, busulfan are known to cause pulmonary fibrosis. Busulfan causes hepatotoxicity. Doxorubicin causes cardiotoxicity. Cyclophosphamide causes hemorrhagic cystitis as well as ifosfamide. So we need to know how to manage that again with increased hydration. Mesna, I'll be coming to that. And of course, myelosuppression. So I'll keep it short, but mostly side effects are either immediate, which is mostly fever, immediate nausea, vomiting, and allergic reactions. Allergic reactions are very, very important. As I mentioned before, with taxanes and platinums, you need to know how to manage them. You need to know when you can re-challenge the patient and when you don't re-challenge the patient. When you're giving chemotherapy, you need to make sure that the emergency tray is close by. Everybody knows the protocols. You need to know how to manage anaphylactic reactions. And this is something that we all learn at a resident level as well. So, and as well as build up upon from our earlier MBBS and MD or MS days. We also have patients where there can be vesicants or irritants. There can be extravasation. You need to know which drug causes what kind of extravasation and what is the mechanism of action. You need to know when to give what to prevent these or to treat these extravasation reactions. We look at the urine discoloration. We have to counsel the patient because patients will panic. You give them doxorubicin, they'll have say a red color urine, because we are counseling, for example, cases where we give VAC, where we give doxorubicin and cyclophosphamide, and we counsel the patient that hemorrhagic cystitis is a side effect, so they'll start panicking. So you need to know your drugs, you need to know the color, you need to tell the patient, okay, you're going to pass red urine initially, but that is not blood and urine, please don't panic. So all of these are things that you need to know. Immediate side effects, like I mentioned, acute emesis is very, 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 very important. Medical oncologists are lay a lot of stress upon antiemetic regimens, and rightfully so, because the patient's entire quality of life depends upon it, right? And sometimes even medically they become quite sick if you don't take care of this. So onset of actions within days are there's the delayed onset emesis, for which we have separate drugs. Then we have fatigue, we have myelosuppression, diarrhea, constipation, general side effects like reduced appetite, metallic taste. We also have side effects that develop within weeks, more notably alopecia. You should know the drugs that cause alopecia. Taxanes cause complete alopecia. So you have complete loss of all hair from the body, including eyebrows and eyelashes and everything. Cisplatin, doxorubicin. We need to know drugs that cause peripheral neuropathy, which is paclitaxel, oxaliplatin, cisplatin. It's very important to tell the patients when we give them oxaliplatin that please avoid drinking cold things, or avoid washing your hands with cold water, because that will lead to an increase in the initial neuropathic component. We tell them to make basic changes to their skin care routine, their hair care routine, their nail care routine. We have patient sheets, information sheets for that. So this also helps in, one, we know how to prevent it, and we maintain the patient's quality of life. In the very end, docetaxel, as you know, causes fluid retention, and this is another favorite question of mine on rounds. We need to give steroids for a few days, a very short course, to prevent this fluid retention. So you need to know your drugs very well. Late side effects, as mentioned before, memory difficulties, ototoxicity. What is very important is sterility, amenorrhea, sexual dysfunction. You need to tell patients in the reproductive age groups that this may happen. Those patients who do not have a family, we counsel them about fertility preservation options, both semen preservation as well as with drugs or embryo preservation. And again, that's a topic in itself, but you need to know, because this also is very, very important from a very medical legal point of view. We document everything very, very carefully. We take high risk consents, we take consents for infertility. If the patient is not willing, we need to counsel them, because then they get very scared also, for example, if they develop amenorrhea suddenly. So this becomes very important. Another aspect is development of late MDS or leukemia, especially with alkylating agents, topoisomerase 2 inhibitors. We need to know, we need to watch out for these issues. Any patient who's developing cytopenias, we keep a low threshold for working them up. And as mentioned before about cardiotoxicity and pulmonary fibrosis, and both of these can be very, very debilitating for the patient and even lead to death. So we have to be very careful about them. Now, there is a very set pattern in which you report these adverse events. So, for somebody who has taken part or is participating in clinical trials, everything depends on CTCAE, and the latest version is 5. So, in short, each toxicity is graded as per their severity. So, just look at the blue highlighted portion. Grade 1 is usually mild asymptomatic toxicities, where there are only clinical or diagnostic observations. We don't really need to do anything. Grade 2 is when they develop moderate symptoms, or there is some small intervention which is indicated, where age appropriated appropriate instrumental activities of daily life is limited. Grade 3 is when these complications become severe and medically significant, but are not immediately life-threatening, but you may need to hospitalize the patient or prolong the hospitalization, or it may limit the self-care ADL of the patient. Grade 4 is life-threatening consequences where you need urgent intervention, and grade 5 is death-related to adverse events. Sometimes grade 4 toxicities may not be life-threatening, like neutropenias or decreased platelet counts, thrombocytopenias, but the grading is grade 4 according to them. So by a general rule, with regard to dose modification for grade 1 and grade 2, we don't really dose modify. For grade 1, we usually go ahead and dose if it's not very significant. For grade 2, it depends on how significant it is. Sometimes we need to hold the drug for some time and then give it at the same, we can give it at the same dose. If there is a prolonged grade 2 toxicity which goes on and on and on for more than a week or 2 weeks, then we consider dose reduction. For grade 3 and grade 4, of course, we either stop the inciting agent altogether, or we re-challenge it after the toxicity has come back to a grade 1, and we give it at a reduced dose, or we add something over to it. So this is very, very important. Certain toxicities we do not re-challenge the drug at all. For example, doxorubicin-based cardiotoxicity, a certain drug-induced ILDs or pulmonary fibrosis. So in short, these are the measures that we use to prevent chemotherapy toxicities. We look at general measures and monitoring. As I mentioned before, we give our patient handouts, we educate the patient, we educate the residents, and we educate ourselves. So it's a continuous learning curve for everybody. We give growth factors either as a primary prophylaxis or a secondary prophylaxis. I will not go into details. To prevent drug-induced myelosuppression, we give specific drugs like dexrazoxane for doxorubicin and mesna to prevent hemorrhagic cystitis and ifosfamide and cyclophosphamide regimens. We give a lot of hydration, as I mentioned before. We are very, 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 very particular about anti-emetic regimens, again, which is a topic for another class. We give steroids for certain indications to prevent allergic reactions, to prevent skin toxicity, to prevent edema, as I mentioned before with docetaxel. We give steroids mostly with as an antiemetic also. So steroids are actually a backbone of cancer chemotherapy. It is part of the chemotherapy only. And antihistaminics we give to prevent allergic reactions. Paclitaxel is known to cause significant hypersensitivity. So most regimens, all regimens in fact with paclitaxel contain antihistaminics. Coming to another aspect of response assessment, that is chemotherapy response assessment. So there are various different methods by which we look at the response of the tumor to the chemotherapy drugs. One, of course, is clinical response. If there's a visible lump, we can see that the lump is decreasing. If there is pain, it starts improving, and so on and so forth. We look at the radiological response by using the RECIST 1.1 criteria. I'll get to that in a minute. We look at the molecular response. MRD is a huge aspect of that, especially in leukemias and minimal residual disease and myelomas, and we also look at now I think circulating tumor DNA and all that is coming up in solid tumors as well. We look at serological responses. A good indicator of that would be, say, CA125 testing in carcinoma ovary, or tumor markers like AFP, beta HCG, or LDH testing in patients with germ cell tumors. That will give us an idea of how well the tumor is responding. It usually starts coming down. We look at the pathological response, where we look at the tumor regression grade. We look at the major pathological response, which is a new term with chemotherapy regimens now, and the pathological complete response, as I mentioned before. So this holds importance in certain tumor types, not all. However, more and more data is coming in. We look at the metabolic response on the PET of these patients by looking at the PERSIST, like the RECIST criteria in radiology, and we look at the Dole 5-point scale for lymphomas, for example. So in short, about RECIST 1.1, we take a two-dimensional look at the tumor. We first decide which tumor lesions we are going to cause it. So for a single lesion, it's easy. That's the target lesion. For multiple lesions, for patients with metastatic disease, we look at what is called as target lesions. So we look at the long axis diameter For your regular target lesion, we look at the short axis diameter for lymph nodes. So long axis diameter, the tumor should be more than 10 mm, and 15 mm short axis diameter for lymph nodes to qualify as a target lesion. We look at maximum 5 target lesions in the entire or the patient scan. We look at maximum 2 lesions per organ. We look at the sum of diameters of all these lesions, and then we follow up with looking at the sum of diameters also along with in the subsequent scans. So for example, complete response means disappearance of all lesions in pathologic lymph nodes, which is less than 10 mm, that is non-pathologic lymph nodes. We look at partial response where there is more than equal to 30% decrease in the sum of the diameters. There are no new lesions. There are no progression of non-target lesions as well. An unequivocal progression as we use it in trial setting terminology. Stable disease is when there's no partial response nor no progressive disease as per this criteria. Disease progression is when there is more than equal to 20% increase in the sum of diameters, and this is compared to the nadir scan. So not the baseline scan. Please remember that when if you're doing serial scans in scan 2 or scan 3 shows that the tumor is at its lowest or the smallest, that is what we'll compare. And if it starts increasing more than equal to 20%, then we call it progressive disease. So an absolute increase should also be there of more than 5 mm for it to be called progressive disease. Non-target lesions are sclerotic bone lesions, pleural fluid, ascites, lymphangitis. So we call it progression only if there is unequivocal progression of them, which is like a for sure progression. Then only we label it as a progressive disease. And this is more applicable to clinical trial settings. However, we use it in daily clinical practice as well. Now, this is almost my last few slides now. So we look at, so it's not just chemotherapy, like I said, and it's the paradigm has changed from just chemotherapy to targeted treatments, VEGF inhibitors, etc., immunotherapy, to combinations of the two. So a lot of data has already come in where combinations are definitely better than chemotherapy itself. So we have chemotherapy and monoclonal antibodies, for example, rituximab and CHOP-based regimens in lymphomas, which is called R-CHOP. We look at chemotherapy plus targeted therapy. For example, HER2 targeted therapy added on to chemotherapy in breast cancer and gastric cancer. We look at chemotherapy and immunotherapy, which is coming into a lot of areas. For example, lung cancer. We look at chemotherapy and anti-angiogenic agents, again in various diseases where they act synergistically. I can think of, top of my head, carcinoma ovary, carcinoma colon, etc. And more to build it up further, the new kid on the block is what we call as antibody drug conjugates. So I'm sure 5 years down the line, this is what we're looking at, which is the future. Now, what happens in antibody drug conjugates? Very shortly, there is a monoclonal antibody which binds to a specific target on the tumor cell, and that is attached to the drug, which is called the payload. That is your chemotherapeutic drug. It is attached to it via a linker. So the linker is cleavable or non-cleavable. I will not go into details about that. And we also look at the antibody drug ratio. And a lot of the latest studies, for example, trastuzumab deruxtecan, more earlier than that, trastuzumab emtansine, that is TDM1. These are all drugs which use this principle, and this leads to better exposure, systemic exposure with less toxicity to the patients. We're seeing more efficacy now in the new trials that are coming up. So this is something that even if you're not a medical oncologist, you need to be aware of, because these drugs come with their own toxicities and adverse event profiles, and you need to know how to give them as well. So I'll end by saying that yes, science does give hope, and we continue to work for it. And please read the book. It's very, very nice. And this reminds me of Dr. Banavli sir. He used to incorporate this book in his presentations when I was in Tata. And a big thank you to everybody, and especially Devan sir and Navneet sir, and all my previous teachers before this. So thank you very much.
Thank you, Dr. Mansi.
Thank you, sir. Okay, I have to.
I'm not finding questions in chat box. Can I ask Mansi, what are the indications of metronomic therapy in head and neck cancers? I have seen prescriptions where left and right, everybody has given metronomic therapy. But what are the indications of metronomic?
So, sir, as of now, the role is more in the palliative setting. When standard chemotherapy, basically platinum-based agents are either contraindicated or the patient progresses on that. As you know, there was data presented in ASCO last year from India, where there was an overall survival benefit with the combination of immunotherapy and oral metronomic chemotherapy. Recently in ESMO, I've not read that presentation yet, but again, there was data presented where it showed an overall survival benefit, oral metronomic chemotherapy. We have multiple trials from abroad as well as India. The gist is to turn head and neck cancer into for those patients where we cannot cure them, into a kind of a chronic state. So that is what we aim for. In the adjuvant setting, there is some data for metronomic chemotherapy. The data is not very strong. It's not come in a phase 3 setting yet, so it's not really accepted by guidelines at the moment. But off-label, we do give it. I mean, we have that discussion for
Adjuvant as
individual
well as
patients.
palliative setting, you said. Adjuvant as well as palliative setting, both.
It's mostly palliative. I would
Mostly.
not say that the role is too much in the curative setting, but yes, more in the palliative setting right now. But
And
trials are ongoing, so it might change in the future.
second, we use cisplatin and carboplatin in addition to radiation for chemoradiotherapy. So, what are the other drugs which can be used with radiation as radiation sensitizers?
So,
For
sir,
head and neck,
5-FU
I'm
can
talking
be
of. I'm
used.
talking of head and neck.
So 5-fluorouracil can be used. A combination of 5-fluorouracil and cisplatin can be used. We can use cetuximab. There is some data for nimotuzumab. There is good data for docetaxel also for those patients who are cisplatin, because carboplatin doesn't work that well. So carboplatin is actually not indicated to that extent. If the patient is ineligible for cisplatin, we use other drugs. We do use carboplatin in certain patients, but it's not considered standard of care. There was some data again from our own Indian setup where docetaxel worked well in these patients, where they could not tolerate cisplatin or there were contraindications to cisplatin. So young patients, cisplatin is a wonderful drug. For elderly patients, those with comorbidities, we have to be very, very careful about our choosing our patient. And
Cetuximab can work.
cetuximab can work, so yes.
Okay, good, very good. And really enlightening the message from Dr. Monica is there. The lecture was very enlightening. I fully agree with Dr. Monica. And you have covered all the basic issues which, as an oncologist, I think everybody should know. Everybody should know. So, if there are no more questions, can we call it a day? Navneet ji?
Yeah, sure, sir. So thank you very much, Dr. Mansi Sharma, for the presentation, and thank you very much, Professor Dr. A.K. Diwan, for joining us. And thank you, trainees, for joining the session.
Thank you, sir.
Thank
Thank you for
you.
the
Thank
opportunity.
you. Thank you.
Thank you, sir.